debunk some bad science,
Yeah.
which was thought to be cutting edge at the time. But live and learn, or perish and learn. Another big paper, that levels of serotonin did not seem to correlate with depressive states. So the sort of hypothesis on, well, you have low serotonin, so that's why you're depressed, may not be as valid as was once thought, although there are quite a few limitations. They only looked at a single subtype of serotonin receptors, and serotonin levels are very difficult to measure. I don't think they were doing brain biopsies on these people.
Probably not. Probably not even LPs.
Yeah, those
which is a lumbar puncture.
Yeah, invasive procedure that carries a significant risk. Those are things you only do if it's exceptionally rare diagnosis or a life and death situation.
Serotonin does not cross the blood-brain barrier. You have peripheral serotonin and central serotonin, which is in your central nervous system. And serotonin is a neurotransmitter based on the tryptophan amino acid, kind of related to melatonin, which is also based on tryptophan. But about 90% of your body's serotonin is peripheral, and much, much less of it is central. And you're going to have most of the therapeutic effect, if you will, of anything to change your serotonin is going to be in the central nervous system.
Yeah, and certainly people can experience the peripheral effects of serotonin.
Definitely.
A common scenario is somebody starts on a medication that increases serotonin. They get a few days or a week of upset stomach initially, and then that tends to subside because receptors sort of regulate and create homeostatic balance in the body. But that's an example of peripheral serotonin sort of quelling or calming anxiety is an example of increased activity of central serotonin, and probably many other actions that SSRIs have. So we know that there's changes in the microbiome, and there's some crosstalk between the microbiome and the brain. You hear about the gut-brain axis more and more now. And then also the increase in BDNF, which is just like exercise is known to have antidepressant qualities. That also increases BDNF, and sort of neuroplasticity is a bit debated with the neurogenesis and the production of new neurons, but certainly the brain to adapt and learn, healthier thought patterns or better coping strategies. It's a bit like unlocking that gate. And then even with, I'm not sure about all of the SSRIs, but I know with sertraline in particular, it increases levels of allopregnanolone, which is a naturally produced metabolite from progesterone, and concentrations of that in the brain do have an anxiety reducing effect. So there's multiple ways that these medications work. So just because serotonin may not be as heavily implicated in a single subtype of the serotonin receptor doesn't, say that they have no clinical validity and that we've wasted billions of dollars developing and paying for these, because
they certainly work.
Yeah, and these can be life-saving medications for many people.
At one point, I mentioned that, if you take someone and they have, say, depression or anxiety, a mild to moderate depression or anxiety, and they ask for a medication, and you don't at least mention the lifestyle measures that you just mentioned. So your exercise increasing serotonin and BDNF, your gut microbiome, your gut health, your diet. Without mentioning those things, it's like you're trying to dig out without a shovel. So obviously I'm a fan of shovels. That should be an assumption. On a scale of 1 to 10, when you mentioned your exercise, you mentioned your gut microbiome, let's throw in lion's mane in there as well for BDNF. On a scale of 1 to 10, how powerful are all three of those interventions when it comes to optimizing your serotonin and BDNF?
I mean, if you take the approach of doing everything you can from a lifestyle standpoint to, dig yourself out or to prevent depression even, that's going to be far more powerful than an SSRI, because we know in many cases, statistically, I think about 70% of people with the more mild or moderate cases get better on an SSRI. A little bit harder for severe depression, but it's going to be more powerful to have everything in place from a lifestyle standpoint than to simply take a pill and expect things to be resolved.
Yep.
even if you are using just a medication because you don't have the ability to exercise, or your diet is not what it needs to be, there's still some work to be done, with cognitive behavioral therapy, or you're actually sitting down and kind of working through these things and making an effort to improve those lifestyle things when you have this extra tool you're using for a bit of a boost, as opposed to taking a pill and then another pill to augment that effect.
Yep.
And neglecting the pillars of health as we commonly talk about.
I agree. And on top of that, if you're an individual and you have never used or utilized a shovel before or a tool, then you should certainly speak with your healthcare provider about how that can be best used. If there's somebody who's never dug a ditch, then even 30 seconds with somebody who has used these tools to dig ditches many times before can be particularly helpful.
Yeah, and I guess I didn't answer your question of a scale of 1 to 10. So we said 70% for mild to moderate. So I have 7 out of 10, I suppose.
Yeah.
How effective is, let's say we take a natural approach where someone is using some omega-3s, they're taking vitamin B6, which had a nice randomized trial that came out lately. They're exercising, they're getting sunlight. And let's assume that they have no issue with the time constraints to do all of these things. Then I would give that a 9 out of 10, because it's not going to work for everybody. But I think anytime you're taking a multifaceted approach over a single faceted approach, there's going to be numerous advantages to that.
Definitely. Another thing that we could mention specifically for depression is if you have a mild to moderate episode of depression, if you do nothing at all in 6 to 12 months, most likely that episode will end as well. The downside of that, it sounds pretty decent, but the reason why most clinicians want to treat it more aggressively is you feel absolutely horrible and you have horrible lifestyle. A lot of times across the board, all 6 pillars, all of those are off for 6 to 12 months, and that's a long time.
Yeah, that's a great point. And, getting someone better faster, it's a goal, but it really is a health journey at the end of the day. And for some people that, haven't had a struggle with depression, if you think of sort of that serotonin pathway, and as you mentioned, the tyramine, for example, or tryptophan, tryptophan, for example, if you are acutely ill, let's say you have the flu, there is some evidence that tryptophan gets converted down a inflammatory pathway. It contributes to some neuroinflammation, and I would say that's fairly similar to what someone would experience with a mild to moderate depression, where everything feels like it takes more effort than it should. You just want to lay in bed. You just feel generally unwell. Now, people with depression certainly don't run fevers 24/7 and have a chronic cough. But that's sort of an idea of what those people might be feeling. And do you want to feel that way for 6 months because it's probably going to get better on its own? Kind of puts it in context of what are your risks and benefits, just like with any intervention.
Speaking of the risk and benefits, a lot of people also ask us, what did people do before we had SSRIs or antidepressants? And obviously there's antidepressants of many different classes. There's NMDA receptor agonists. There is dopaminergic medications. There's non-SSRI serotonergic medications. I believe we've podcasted on this before. Before we had those medications, people just felt horrible for that amount of time. However, people in general were better at the lifestyle interventions. But the best of both worlds is both. People also used to have horrible sleep and be extremely stressed. And a lot of their basic physical needs, if you think throughout human history, the last thousands of years, those have not been met. And a lot of times they just died earlier.
Yeah, if you look at it in a very evolutionary standpoint, you would have thought that depression would have been selected out. But we do have the capacity to care about our sick population, so that probably has carried it forward to some degree. But yeah, I mean, you even see that now with the data and people who are optimistic versus pessimistic. And again, there's always the debate of, well, are they just optimistic because they've had good luck and they're healthy, or are they pessimistic because they've been dealt a bad hand? But in general, being optimistic as opposed to being depressed is going to be associated with significantly better health. So I say it all the time that in general, you want to do things that are associated with outcomes and
Yep.
avoid things that are associated with worse outcomes.
Absolutely. And we have been, we being the medical community, even if you think back to Averroes 1,000 years ago, or Galen, even before that, we have been fighting natural selection for a long time.
Yeah, it's an interesting rabbit hole we could get down. Perhaps we talk about some historical medical practices in another podcast.
Absolutely.
Time, but yeah, live and learn or perish and learn.